It is important to remove this polyp before we try the IVF cycle. Second is an endometrioma. If the ovary is already having ovarian cysts, it is always better to remove cysts more than 5 centimeters before offering IVF. Similarly, with large fibroids or small fibroids that are coming into the endometrial cavity. So assessment is very important. In male factor, again, whether we need to do simple in vitro fertilization or try intracytoplasmic sperm injection. Infectious disease screening, HIV, hepatitis B, VDRL screening needs to be done. Need a pointer. In IVF, what we need to explain to the couple is not all couples who undergo the treatment will become pregnant in the first cycle itself. So if we look at this slide, which says that suppose there are 100 patients who started the treatment cycle, not all would end up with egg collection, not all would have embryos suitable for transfer, not all would get pregnant, and not all would carry a baby to term. If this is explained to the couple that there is about a 30 to 40% positive pregnancy rate per cycle and about a 20 to 25% take-home baby rate, and explain to them why this decline happens. It is not because we don't want them to get pregnant the first time, but this is what it is about. We don't know why some embryos would definitely divide inside to have a baby and some would not. However, certain factors can be treated beforehand, like I already explained. This is a cycle guide. Looks very busy slide, but basically, just to be brief, the IVF cycle starts on day 1 of the period when you start off with the injection. Then egg retrieval about on the 13th to the 15th day, and 2 weeks later is when we do the beta HCG to find out whether the lady has got pregnant or not. These are protocols with which we follow how to monitor the patient. This is how an ovary looks like when it has been stimulated with drugs. I want the lights to be dimmed, please. This is the egg retrieval process going on. This is a hyperstimulated ovary in which the needle goes in to aspirate the fluid, and then the ovary looks like this. Once all the fluid is collected, then the fluid goes to the lab for examination to look for the eggs. Once the egg collection is done, this is how the egg looks like under the microscope. The sperms and the eggs are mixed in these dishes and put into the incubator. The media we use, the incubators, the instruments that we use to fertilize the egg may have some outcome on the result. However, clean, standard, routine IVF practice should help us in giving wonderful embryos. Our previous speaker just elucidated how the embryos look like. This is a day 2 embryo with 4 cells, and this is how the embryos look as the days go on inside the lab. Embryo transfer is one of the most crucial steps of an IVF process. You have stimulated the eggs, the lady collected the eggs, formed the embryos, and now the embryo needs to go in exactly at the right place to give the lady the best chance to get pregnant. This is how the embryos are loaded. This is an air bubble, this is media, these are the embryos, another air bubble and media. These air bubbles are added so that we can see the embryos under ultrasound vision while we transfer the embryos. After the embryo transfer, 2 weeks later is the positive pregnancy test which we are all looking for, and then 2 weeks later we do the ultrasound to see if there is a heartbeat in the baby. There are other IVF techniques which I shall briefly elucidate. For example, cryopreservation, freezing the sperm freezing embryos and freezing eggs. One which all of us should keep in mind is for cancer patients, malignancy patients, young men who are undergoing radiation or chemotherapy. This should always be offered to them so that they can freeze their sperm in order to preserve fertility for later use. Similarly, we can offer this to a lady undergoing radiation or chemotherapy. If she wants to undergo an IVF cycle prior, freeze the embryo so that her fertility status remains intact. Dr. Subramaniam has elucidated on the methods of removing sperm from obstructive azoospermia. We also have donor sperm, egg and embryo program for patients in whom there is either non-obstructive azoospermia, premature ovarian failure, or in which there is irreversible endometrial damage. These 3 slides I will brush through, but they are important. This is to show that how we need to legislate and bring into regulation IVF practice in our country so that it can be regulated and we can give a wholesome, transparent look to our patient as to how many cycles we start, how many are getting pregnant. This is a very new situation that our country is facing. We are becoming better and better with IVF. We are quite cheap, so the world is getting attracted towards us, and the ICMR guidelines have also been very open. They are allowing treatment in same-sex couples. They are allowing treatment for single parents, and of course surrogacy is allowed by the ICMR guidelines. Now what can we do to improve this 30 to 40% to 40 to 60 and then maybe beyond? A lot of research is going on in this direction. First is to improve the embryo quality, and second is implantation. What happens when the wonderful embryos go in and there is negative pregnancy test? We just heard about pre-implantation genetic screening in the previous talk, in which in repeated IVF failures or in which there is supposed thalassemia, sickle cell, and the patients don't want to undergo first trimester termination of pregnancy, we can take a cell out and do the studies and then implant the embryo back. Implantation is by improving the blood flow to the uterus. Sometimes giving aspirin, low-dose heparin, steroids may help in improving the pregnancy rates. At the end, we are all looking for a final aim, which is healthy baby and a happy family. There was a small remark about IVF leading to more congenital malformations. I would like to have a small comment on that. The normal congenital malformation in the natural population is major malformation is about 3 to 4% for couples who are trying naturally. In IVF, this has been shown to be increased by 1%, mainly cardiac malformations, but not overall to the tune of 10, 15 or anything. So we need to counsel our patients that yes, it is slightly increased, but not hugely so. Finally, I would like to conclude by saying that infertility is a very major problem. 10% of all couples in the reproductive age group are facing it. It is essential very early to diagnose what the problem is and to do the right treatment at the right time. We need to have, as most centers do, standardized, well-equipped lab with trained personnel. Maintenance of standard pregnancy rate is essential, and we need to continue with our research focus to improve IVF pregnancy rates. Thank you for your patient hearing.
Excellent lecture, Dr. Kaberi Banerjee. And I'll just brief you in 2 lines. We started our center in '94. And today is 2010, 16 years, and I have seen scenario changing. When we started, IVF was at a very preliminary stage. Only tubal factors patients, female patients used to be treated. But now the time has come. If you have a desire to have a baby, maybe you are married or not married, maybe you are two ladies or 2 males, you have a desire, you can get it. So, and thanks to ICMR guidelines, they have been simplified, and medical